Our second speaker for the webinar is Dr. William Lee, another well-known leader in our field. He's a professor of medicine, and he's the founder and principal investigator on our NIDDK-funded acute liver failure study group, which is a very famous study. He's also participated as a principal investigator in our other studies, such as HALT-C and Dylan, and of course the HBRN. Dr. Lee is going to summarize the HBRN's ancillary study on acute hepatitis B that was occurring. Dr. Lee.
Thank you, Jay. Let me get my slide up here. Thank you, Jay and Dr. Ward, for allowing me to participate in this wonderful three-pronged review of the HBRN network. My job is to review for you this morning in brief the acute Hep B study that we did as a sub-study of the overall HBRN. You've heard in detail Anna's background information about the chronic cohort, but this was a specific small sub-study that we did looking at acute hepatitis B infection. Here are my disclosures. None of them relate to hepatitis B, by the way. So by way of background, we've had a safe and effective vaccine for hepatitis B for more than 3 decades. But if we think back, most of the studies that were done looking at the natural history of acute hepatitis B occurred in the 1970s and 1980s. So here we are 50 years later, 3 decades after vaccines became available, and we still see more than 3,000 cases of acute hepatitis B recorded by CDC. We decided that there weren't any recent studies and that this would be a good reason to use the mechanism of HBRN, the study sites that you just heard about, as a focal point to enroll some cases with acute hepatitis B. And our main outcome paper is the paper cited here, Sterling et al., shown here. My colleagues on this paper were Richard Sterling from VCU, Abdus Wahed from Pittsburgh, Gavin Cloherty from Abbott, and Jay Hufnagel, and myself. So we tried to find patients, most of whom were hospitalized with acute hepatitis B infection at our participating centers, and used a similar sort of design as the chronic study with some unique features. We gathered all the same demographics, clinical features, and in this case, 12-month outcomes of consecutive patients with acute Hep B prospectively tracked and compared these, the features of the acute Hep B patients with those of the contemporaneous chronic cohort. There were some differences, as you can imagine, for acute hepatitis B patients. First of all, they were virtually all hospitalized and had moderately severe hepatitis at the time. That's why they came to our attention. But we also were interested in following them much more closely, as you can see here, at baseline weeks 1, 2, 4, 6, 8, 12, 18, 24, and 48. I will say, though, we had to be somewhat flexible because patients were typically only hospitalized for 4 days or perhaps up to 7 days with their acute illness, and then needed to come back and see us frequently at a time when they actually were feeling quite well, and they presumed on clinical grounds that their infection had resolved. What we did to identify, to be certain that these were true acute hep cases, were to have a committee, adjudication committee, review them after we gathered all the data. So our criteria for calling them acute Hep B included detection of anti-core IgM antibody. Most all of them had HBsAg as well, but not quite all. And they had to have had a clinical picture that we felt was compatible with acute hepatitis B. We wanted to be sure that they didn't have any evidence of chronic Hep B, but of course that isn't always available. We don't always have prior HBsAg testing on people that come in with acute infection. Many of them didn't know whether they'd ever had Hep B testing before. We used an additional caveat, which was that the clinician involved in caring for the patient had to confirm the diagnosis in his or her narrative. And then, as I say, we went through the adjudication committee once all the data was in hand. Beyond the usual standard testing for acute infection or chronic Hep B infection, we also were able to perform quantitative surface antigen testing, quantitative e-antigen testing. We were able to also sequence for pre-core and basal core promoter mutations and do some quantitative HBV RNA and correlated antigen levels. So here's the schema of our comparison between the chronic cohort and the acute cohort as shown here. So there were approximately 1,900 patients with chronic Hep B, and we included the 3 from the acute study who appeared to have chronic infection, but excluded, as you heard Dr. Locke say, those that had co-infection with HIV-C infection or Delta infection, and also those that participated in the therapy trials. So the cohort for this particular comparison was 1,534 chronic HBV patients. In our acute cohort, we had 66 patients, but with adjudication by the committee, we ruled out 3 with chronic infection and 3 where we just didn't have enough data to be certain that they represented acute HBV. Of the 60 patients, 56 had full data, or at least some valuable longitudinal data, and 4 only had baseline data exclusively. So we based the longitudinal studies on the 56 that had significant data there. So on baseline, the ages between the acute and the chronic group were essentially identical, but there were lots of differences otherwise. Male sex in 72% of the acute versus 50-50 in the chronics. Many more whites and blacks in the acute study than in the chronic study, as you heard Dr. Locke say. And again, virtually no Asian Americans in the acute study, just 1 elderly man. Again, mostly white patients, 50% white, 25% black. And amongst the other group, they were mostly Hispanic Americans. The difference, which again came out in Dr. Locke's study, was that only 18% of the chronic patients were born in North America, whereas in the acute study, 80% were North American born. And again, the other difference that is we expected, frankly, was that most of the cases represented sexual transmission with a smaller fraction representing injection drug use. So again, the acute hepatitis B profile was a man, either white or black, not Asian, born in the US, and with suspected sexual transmission. And of the sexual transmissions, about 1/3 of those, or 25% of the overall group, were considered to be same gender sexual transmission. So the serologic features are shown here, again, with the acute column on the left and the chronics on the right. There was about 1.2 log higher viral load of HBV DNA in the acute group. Many more e-antigen positives, as we might expect, although perhaps surprisingly, 27% were e-antigen negative at presentation. And I'll say a little bit more about that in a moment. The genotypes, again, differed greatly from the chronic study in that 69% were genotype A, and only 1 or 2 patients genotypes, I think just 1 patient genotype C. And comparing to the chronic group, obviously there were 70-some% of genotypes B and C in the chronic group, as Dr. Locke outlined. So again, amongst the e-antigen negatives, there were several that had the pre-core mutation, several others that had the basal core promoter mutation, but only 2 of these had the pre-core or basal core promoter as the most prominent quasi-species. So we're unclear whether these patients represent infection from an E-negative contact, or whether these are simply the evolution of E-negativity during the evolution of the acute infection. Against it being evolution during acute infection is the fact that the E-negative group and the E-positive group had essentially the same amount of time between onset of symptoms and onset of enrollment in the study. So there wasn't a longer duration of time to enrollment in the E negative group. Looking at age comparing to risk factors, again, it's pretty even across the different decades, with sexual transmission relatively even across the 4 different decades. And again, only 4 patients above the age of 60. Again, looking at decade of birth and whether people were US born or foreign born, again, most of them were in these middle decades, 60s, 70s, and 80s for their date of birth. And we were quite interested in looking at time to loss of HBsAg and gain of anti-HBs. And the sort of classic mantra has been that we call it chronic hepatitis B if your HBsAg hasn't cleared by 6 months. And we were quite surprised to see, as you can see in this slide, that the median time to surface antigen negativity for this cohort was actually 26.4 weeks. And the median time for anti-HBs appearance was 37 weeks. So the time to HBsAg clearance was longer, and only half had cleared by 24 weeks into their illness. And again, anti-HBs many weeks later, and 15 to 20% by the time the study was over had not developed anti-HBs. This is certainly longer than we had predicted we would see. So what risk factors were associated with time to HBsAg loss? Well, not very many. So some of us clinicians thought going into this that female sex and higher aminotransferases were associated, and that women getting acute Hep B tended to have higher enzymes, higher bilirubins, and to clear virus surface antigen earlier. That did not appear to be the case. Neither age, gender, race, mode of transmission were associated with a longer time to surface antigen, or a shorter time for that matter. Nor was the severity of the infection associated with more rapid surface antigen clearance. Longer time did appear to be associated, but these are somewhat soft, with initial level of HBV DNA, presence of E antigen, and initial HBsAg concentration, but not with initial concentration of E antigen or HBV genotype. 2 patients did appear to develop chronic hepatitis B, in that at 2 years following their infection, they were still surface antigen positive. Of note, both had had relatively mild infections during their acute phase. So in summary, in this small group of patients enrolled between 2011 and 2017, most were men with symptomatic ecteric hepatitis, positive surface antigen HBV DNA, and IgM anticore positive. In contrast to chronic Hep B, most of the acute cases were white or black, born in the US, had sexual exposure as their route of infection, and carried genotype A2. So in conclusion, there's a wide age range for these patients, and but it's noteworthy that all but 2 were born before 1991, suggesting that HBV vaccination, which was initiated at that time, has been effective in eliminating acute Hep B infection. But in this cohort, the time to clearance was longer than we expected, more than 6 months in half of the patients, suggesting that routine definition of Hep B should be now not 6 months, but probably 12 months duration for us to declare that someone has a chronic infection. We're suggesting on the basis of these findings that CDC may wish to change its vaccine strategy recommendation. The current recommendation is that it's recommended for those 59 or younger, and for 60 or older only in people who have a specific risk factor. Since we had 4 patients greater than 60 years of age, most of whom didn't have an identifiable risk factor, we would suggest that the vaccine strategy should be vaccinate everyone between ages 30 and 80 as one possible suggestion for revision to the CDC current recommendations. Again, I'd like to acknowledge our funding sources for these studies and the study sites that participated in the study. Thank you, and I'd be happy to address any questions.
Thank you, Will. That was terrific. We have a few questions we can address quickly. One question from Dr. Ghani is, these data strongly advocate for catch-up HPV vaccination in U.S. adults. What do you say about that?
Yeah, I think I don't think we've been as proactive in getting people in the older age group vaccinated for sure. And again, if we don't know the risk factors, I think we should try to spread a wider net.
So I guess another question is, let me see here. Was there any change in proportion of patients with acute hepatitis B who reported injection drug use over time?
Again, the years of the study were 2011 to 17, and I'm not aware that there was any difference over the time period of the study. But again, it's a small study. The limitations of the study were both the small size, also the fact that they were all hospitalized patients. We don't know how many patients might, be community infected within the community, see a physician once or twice and not be sick enough to be hospitalized. And the third point is that our follow-up was, as I implied earlier, was a little bit limited simply because people that felt well didn't necessarily want to come back for multiple follow-up visits.
So we should point out only 10% of patients admitted to injection drug use. A very large group were gay men with hepatitis B, and it points to the fact that we're failing to, get to everyone who actually has risk factors and deserves to be vaccinated.
Exactly. I mean, how often does a clinician, let's say a primary care physician, explore risk factors fully?
Right.
I guess that leads to the recommendation that everyone should be considered for possible Hep B vaccination, everyone over 30.
Well, the trouble is there's so many risk factors that it's difficult. But the one risk factor that didn't show up was being born abroad, right?
That's correct.
That's a risk factor for screening for hepatitis B.
Right.
A very big risk factor, right?
Right.
But for vaccination, it's strange that we didn't see acute hepatitis B in family members, for instance, of patients with chronic hepatitis B as a risk factor.
No, to my knowledge, there were no patients in that category.
I think it's important to point out too that the Asian patient that was included in here was born in the United States and had a genotype that's not typical of Asia. So it clearly was sexual transmission in a person who was an Asian American.
Yeah.
So we had another question about false positivity as far as antibody after vaccination. Brian McMahon, you're there. Maybe you'd talk about that. In testing people who've been vaccinated many years before, do you pay attention to whether they have antibodies still? Does that make a difference?
Yeah, I don't think so. We just published our 35-year follow-up study in hepatology. I think a couple months ago it came out, where we vaccinated prior to the licensure of about 1,500 people. In Western Alaska is the only area in the U.S. that's endemic for HBV among the Yupik and Inupiat Eskimo population. And we followed the patients that we vaccinated for 35 years, and a couple of comments that would pertain to Dr. Lee's discussion. First of all, there were about 25 breakthrough infections in people who actually responded to the vaccine and developed anti-HBs. And of those 25 infections, none of them had acute symptomatic. None of them became chronic. They lost HBsAg within a year of the time they were infected. and none of them have had any adverse outcomes as far as liver disease goes. So I think the vaccine protects, and furthermore, if they lost HBsAg, which more than half did after, or anti-HBs, excuse me, after vaccination, 90% responded to a booster dose. And so we feel that the vaccine does last for a long period of time. Anti-HBs can disappear after vaccination. And many people, especially older people, are vaccinated, but that doesn't mean that they're not immune to reinfection. I think they are immune, and I don't think booster doses are really necessary, if that answers the
Not
question.
yet, at least. Booster dose might be recommended for very high risk people, but
Immunosuppressed people, I think.
Doesn't seem to be
could-
necessary. And I
Yeah.
think studies support that as well. One question, Will, we had is, were people with acute hepatitis B treated?
Yeah, that's an interesting question.
Nucleoside?
There were just 4 or 5 that were treated with nucleoside analog just in hospital. And again, no one developed acute liver failure. No one seemed to have very severe disease or progression towards ALF.
Right, okay. I think we need to move on to the next presentation. There were some other questions. We'll come back to some of those.
Sure.
One of the questions relates to, are the samples from these studies available for study? And the answer to that is they will be. At the conclusion of the HBRN, the data as well as the samples will be placed in the NIDDK repository from which you can apply to obtain them for ancillary studies of serology, for instance, and so forth. So that will occur. They're not quite ready yet because the study is just now winding up, but we are going to deposit all this. And we'd encourage you to use them, to come back to them and look at them. There are many questions that could be answered from these samples.